First, now there's no one answer. They said, I wanted to list down. So there'll be, it could be anything, right? So now this child we have only this history, a 4-month-old baby. We don't know what the past history is. Coming with the episodes of income, so many details. So I wanted to think about it, right? And so there are. So I want to at least list down 10 conditions, right? So take time, don't be in a hurry. So then we'll build. Right. So milli infection, meningitis, fracture, constipation, severe nephritis, interception, otitis media, pneumonia, cardiac causes, respiratory difficulty, bowel obstruction, UTI, inadequate breast milk, nephritis. Very good. Okay. Constipation, UTI. Very good. You are thinking. Good. Carry on. Okay. Encephalitis, otitis media, abdominal pain. All right. Come on, come on. Loads more, loads more. Insect bite. Oh, there you are. Good. Okay. Sweetie. Your retention. All right. Very good. Okay. Gastroenteritis, bowel obstruction, volvulus, cyanotic heart disease, feeding problems, dehydration, tonsillitis, inborn errors. Okay. Inborn error of metabolism. How? Okay. So then, not directly. Okay. Obstructed inguinal hernia. Very good. Okay. Interception. Come on. Insufficient food. Very good. Okay. Very good. UTI. Colic, infantile colic. Very good. Okay. Right. Okay. So we can see now a baby will present like with excessive crying. Now there are 1,001 causes which are possible. Okay. So unless you have a plan, it's very difficult, isn't it? So now these conditions can be babies tend to present even with just simple nasal obstruction, not uncommon. Early in the morning, so we get nasal breathers. So blocked nose means like uh, as if like in us is obstructed nose and mouth both like. Right? So and also in addition to this, the simple condition, you can have severe conditions like meningitis. As most of you said, evolving CP, SVT, myocarditis, volvulus, torsion of the testis. Now, it could be anything, isn't it? So, what you can do is you should have a way of not to miss a diagnosis. What I suggest to you is think of conditions that can present from top to bottom, starting from your head to your tip of your feet. Okay, as an example. Okay, now in the head area, what are the possible causes presenting at excessive crying? So we'll ask Tusa or anybody. So you can Himansa or Shavin or anybody. What are the conditions that can present with problems in the head area, head and neck area? We said one is the blocked nose. What else? Anybody? Come on. It's
Meningitis.
Okay, meningitis, encephalitis, very good. Okay, what else?
Head injury.
Head injury, okay. What else? Even a insect bite on your scalp, which can be not be easy to find out. The babies can't tell. You and I can tell, but not babies. Okay, they will just cry. Now you and I will be able to tell. Okay, there's some pain in my head. Okay, but they will not. Okay, so it's very important to think of conditions. Okay, head. So then some foreign body on your eye. Okay, then you can have conjunctivitis, early conjunctivitis, okay? Blocked nose, as you said, right? Then ear problems in the ear, throat infection, right? Then child who now unlikely to have teeth by now, so then it's related to the teeth, right? So then you can go to the chest. So in the chest you can have some, as somebody said, SVT, as you said earlier. Then you can have conditions with presenting with the heart failure. So all the causes like SVTs, you can have myocarditis, pericarditis, right? They all are possible. Okay. So then when you go down, you can have abdominal conditions. Some of you mentioned volvulus, strangulation, interception, obstruction. So then you can have obstructed inguinal hernia, torsion of the testis. So all are possible. So what I want to learn now is, if you have a child presenting with excessive crying, think of conditions from top to bottom, and then you take the history and do the examination with those DDs in mind. So then you will not miss the conditions. Okay. Right. So further about this child, this baby was born at term by normal vaginal delivery with a birth weight of 3 kilos as a firstborn to non-consanguineous parents. He had an uneventful antenatal history but had a stormy neonatal period. The baby was admitted to SPU and was ventilated for 1 week due to product weight was at 3 months, that is 1 month ago, it was 4.3 kilos, and the current weight is 4.8 kilos. Mom feels that he is beginning to have social smile. Okay. Now I want you to just go through this further details of this patient and think about the development of this baby and the growth of this baby. Okay. Then I want you to comment about it. Right. So think only about the development and the growth of this baby at 4 months. These are the findings. So born at 3 kilos, now is 4.8 kilos. And the development. Okay. Fine. So we'll now start. May I ask Theopalan Abrami or Sadipa Tilakrat, who is fine. So what about the development? Just comment about the development. Anybody? Is it normal development or delayed development?
Delayed development.
Delayed development. Why do you say so?
Social mile should be there by about 6 to 8 weeks.
Yeah, by about 6 weeks, so at least by 8 weeks, the social smile should have been there. Very good. So this baby is now 4 months. It's just beginning. So it looks like though there are no other features of development of this baby given. So most probably this one has delayed development. Now think about the growth and the weight. Now think about the weight. What do you think about the weight? Is it sufficient or not sufficient?
Not sufficient.
Not sufficient. Okay, fine. So now, can you tell me why you are saying not sufficient?
By this time, the birth weight should have doubled.
Generally, the birth weight should be should double by about 5 months, right? So 5 to maybe 6 months, close to but at least 5 months. So, but yeah, so if you think that way, then obviously 4.8 kilos is not sufficient, is it? And also, what happens to the birth weight? Now, when the baby is born, you all know that initially there'll be reduction in the birth weight up to 10% loss is allowed, right? Not more than that. So not all the babies will lose 10%, but maybe 5 to 10%. Okay, and this regained by about 10 days, or sometimes it can go up to 14 days. Then we know it goes up by roughly 150 to 200 grams a week, and then after about 3 months, it reduces to about 20 to 25 grams a day. Okay, so it should double by a 5 months. So obviously, the weight seems inadequate. And also, when you evaluate the growth, I'm sure you are aware that it's very important to look at the growth chart, because you need the trajectory or the pattern, how the child has been growing. Okay, fine. So now we know the weight, what as looks like, is inadequate. So what else do we need to evaluate growth further? What other information do we need?
Height.
Okay, so this age we don't tell height, but it's length. Okay, length and the OFC. Now OFC. Okay, so we look at the OFC. We didn't cover the OFC. Okay, so the length at birth is 50 centimeters of the child. Current is 63, and weight for length is -3 of this baby. Okay, now this baby had an OFC of 35 centimeters at birth. Now it's 40 centimeters. So you can see the length also has not been increasing as expected, but it's less affected than the weight. And also OFC is more worrying is OFC, right? You can see it was at the 50th centile at birth, but now is in the 10th centile. So what happens to the OFC? How do you have any idea how the OFC increases after birth? Anybody? Yeah. So yeah. Initially they gain about by 1 centimeter. Right? So initially up to about 6 months, and after that is got by 0.5. So by the time they complete 1 year, they gain about 10 to 12 centimeters. So that's roughly. So always go by the center, the chart, OFC charts. Now you can see obviously the OFC has not increased the way that we want. Now we have now found out there are few issues in this baby. So one thing is a growth issue. The weight is inadequate, the length is inadequate, and OFC is also inadequate. And we found that child has delayed development as well. Now you need to evaluate this further. Now what do you need? A proper history about this child. Now this baby is exclusively breastfed, and mom feels that the baby is always hungry. She feels her breast seems heavy but not getting emptied completely after a feed. So she has been giving express milk via a cup, which she drinks slowly over a period of 4 to 5 minutes. Right. Now, what are the DDs for the excessive crying now? So now becoming more and more bit serious about this condition now. Just think again. Now, what are the problems are you still having now? Looks like the baby is hungry, but looks like he's unable to take the amount that he needs. Okay, and mother has been trying to give with a express milk via a cup, and also he drinks slowly over a period of 45 minutes. It takes a longer period of time. Now think. What are the possibilities now? You can put in the chat box if you want. Okay, so difficulty in sucking. Okay, looks like yes, there's a okay cleft palate is there. All right, cleft palate. Somebody says cleft palate. All right. Now come now. Don't take one feature only. Now you know what the child has. So if somebody says meningitis, impaired swallowing. Okay, carry on. Okay, some more. Pylori stenosis. CP, heart failure. All right. Meningitis, not proper feeding technique, constipation, bowel obstruction. Okay. Congenital heart disease. Right. So we'll go back now. Right. Now, the history is such that now, if you go back to the history, baby was born without any complication, but had perinatal event. So he had been ventilated for 1 week, and now we find that baby has delayed development and poor growth, including the OFC. And now we find that there's a feeding issue as well. Now we have to put everything together, okay, and think as a whole. What are the possible causes for the excessive crying now? So we all, I think, we can understand that this child has some neurological impairment, which is becoming more and more obvious now, isn't it? Okay. So head is not growing well, and also has feeding difficulty. It takes a longer time to feed. Okay, somebody is very good. Evolving CP, very good. Yes, there's some. Yeah, it looks like this child is having evolving CP. Very good. Now, if it's evolving CP, what are the possible causes for this one's excessive crying episodes? Right. So when you have a child with excessive certain problems they encounter, one is that they are at a higher risk of what we call gastroesophageal reflux disease. Okay, GORD. So it's one of the commonest things. Now, in addition to that, this baby takes a long time to feed. So as somebody said, there's a swallowing difficulty as well. When somebody has swallowing difficulty, what is the other problem? Yeah. So somebody has swallowing difficulties. It's a child with evolving CP probably. Aspiration, very good. Whether there's a aspiration, whether the child is getting recurrent aspiration, very good. Yeah. So whether child is getting recurrent aspirations. And also, what other possibilities? Now, this is a child who is having probably evolving cerebral palsy, okay, and episodes of excessive crying. What are the possibilities? GORD aspirations agreed. What else would be? If you think, okay, dystonic reactions, very good. Okay, achalasia, the cardia is not common in them, but reflux is aspiration pneumonia. Yes, we agree. Aspiration pneumonia, GORD, and aspiration pneumonia possibilities. What else? Now, is a probable evolving cerebral palsy. Now, what are the other complications that cerebral palsy babies are at a risk of developing? Seizures, exactly. Very good. So Lienage, yeah. So whether this could be a seizure, right? Because in children, it's most especially the small babies, you may not have all the features that you will see, you would expect to see in a bigger child. Okay? So they tend to present with quite atypical features. So episodes of excessive crying, whether this is a feature of seizures. Very good. Now, with that, how are you going to now proceed further? What are the other important aspects in the history, and how would you examine this baby? First, we go to the history. How would you uh, read this child's history further? Okay, constipation is also common in them. Very good. Somebody has said constipation. Okay, fine. So, what are the important things in history? I'll give you 1 minute to think about it. So now I want you to think about this baby as a whole now. Okay, I'm sure you can now visualize this baby who had neonatal insult with now poor growth and poor development, with a feeding difficulty, with excessive crying. So, and you have few DDs in mind now, including GORD, aspiration, and the seizures. Okay. Okay. So you need to have now additional details. Yes. The baby has fed features of possible GORD and has been started on omeprazole and domperidone by the GP 2 weeks back. Mom feels the reflux symptoms have marginally improved since then. The baby did not have features of aspiration of milk. Okay, now what? So we had few DDs, and then now by further examination in history, we have now sorted out 2 of them. Now we are left with 1. Okay, so whether you are dealing with a now seizures. Okay, and okay, so now this is type. This time it's very important to find out whether there's a video clip. Now almost all the parents have video clip taken of this type of babies. Okay, so this mother also is a true scenario, right? Okay, so this mother, I tried to get the video, but I could not get into the. So what it said was it showed was the baby tends to develop abnormal flexing of the trunk prior to the onset of incessant crying. This has recurred several times the previous day. Now, what is the explanation for excessive crying? Now think about it. I'll give you 30 seconds for the answer now. Very good. Yes. So you are dealing with a infantile spasm. Okay. So I'm sorry. Right. So then we are dealing with a child with a excessive infantile spasm. Right. Very good. So now, what are the specific signs that you would look for in this baby? Now we know this baby now has infantile spasms, and there are certain signs now you should be looking for in this baby. Now I'll give you 30 seconds for the signs that you look for. Okay, very good. Somebody says tuberous sclerosis causing. So what are signs? I'm asking signs. Specific signs. Ashley spots, okay. Not okay. Yeah, so ash leaf spots, okay. So by this age, is it typically almost always you find only ash leaf spots. So later on, what are the other features of tuberous sclerosis that you can get? You can either comment or you can write. What are the other features of Sjogren patch, adenoma sebaceum? Okay, rhabdomyomas, right? Sjogren, but the signs, yeah, Sjogren patch, adenoma sebaceum, and the fingers. What would you see? Subungular fibromas, exactly. Yeah. So okay. So now, in addition to tuberous sclerosis, what other features that you are interested in? Yes, subungular fibromas. Yes. So what are the other features of this child that you can expect? Now, infantile spasms is common in patients with tuberous sclerosis. Agreed. In addition to that, what other signs, that clinical signs that you would look for in this baby? No, I'm asking signs. Somebody says EG findings. No, I'm saying clinical signs. Okay, look for other neurocutaneous manifestations. Okay, right. Okay, port fine stains, right, blanching rashes. Now, just forget about neurocutaneous syndromes. Now, this child, now we know, has had perinatal insult and with meconium aspiration syndrome, and now with features of delayed development. Wow, now we are talking. Yes. So you do a neurological examination with including lower limbs and upper limbs and the cranial nerves. So the limbs, and you will find that the reflexes to be what? Exaggerated, right? And also tone to be hypertonia. Okay, very good. And also you might have other features of upper motor neuron signs. Very good. So he's found to have no neurocutaneous manifestations. There is hypertonia in all four limbs with exaggerated reflexes. Okay, now tell me, I want you to either tell me or put in the chat box, say the complete diagnosis now. Okay, you can contract this. Now I want you to put the complete diagnosis now. Quadriplegic cerebral palsy is incomplete. Now put everything together. Then you have a complete diagnosis. That's what we want even in the exam scenario. Okay, quadriplegic CP due to meconium aspiration syndrome, complicated with infantile spasm. Very good. That's what this child is having. Yeah, well done. Yeah, right. Now, so it's a quadriplegic CP following meconium aspiration syndrome, complicated by infantile spasm. Now, what would you do? What are the investigations that you will request? What do you request? You can tell now. You can tell. Everybody, come on. Okay. So yes, it's an EEG, right? What would you expect in the EEG? Hypsarrhythmia. Very good. So you would expect EEG, and also you will need a imaging as well. Good. So now EEG reveals hypsarrhythmia. Okay. So now what is the diagnosis? Now I need the complete diagnosis now. Now we'll see whether somebody going to tell the complete diagnosis now. I'll give you 1 minute. Okay, so West syndrome, very good. So it's a West syndrome, very good. So it's a child is having West syndrome. So basically having infantile spasms, mental retardation, and hypsarrhythmia in the EEG. So that's what this child is having, right? So this now we have a diagnosis now. So these patients will need pharmacotherapy, and then you have to find the etiology etiology diagnosis and management, counseling and follow-up. So the patients with tuberous sclerosis with infantile spasms, you try to start on vigabatrin, but others you start on steroids. So sometimes you might need other anti-epileptic drugs as well. Well done, right? Okay. Right. Now what we'll do is we'll move on to few questions related to excessive crying, and then move some other MCQs in the other half. Okay, right. So now we'll see. A previously well 18-month-old baby presents with episodes of excessive crying followed by cyanosis. The crying generally starts with a tantrum when he is not given what he asks for. This is followed by flacidity for about 2 minutes and is recovered completely. What is the most likely diagnosis? Again, best of 5. Huh? I'll give 1 minute for that. So most of you say it's a breath holding spell. Somebody says tetragophallo. Breath holding spell. Yeah. So most of you have got it. Somebody says vasovagal attacks, right? So it's a cyanotic breath holding spell. Okay. So looks like it's a quite obvious, but you can sometimes go wrong. So you should know the typical features of breath holding spells. So most you all know there are 2 types of breath holding spells. One is cyanotic, other one is a pallid one. Cyanotic is a commoner type. So there you have, before cyanosis, the baby has a reason to start crying. So sometimes you have to be careful. Sometimes you can have a seizure presenting like this as well. Okay, but here it's very clear. So it has started with a tantrum, and then followed by that usually they hold breath and become cyano. Sometimes you can have a couple of tonic movements as well. Okay, so it's a cyanotic breath holding spell. Right. Next, a 9-month-old baby is seen due to episodic excessive crying for 1 day duration. He has been well in the past with normal growth and development. The baby feeds well in between the crying episodes and suddenly starts crying with flexed legs over the abdomen. Examination is unremarkable. What is the investigation you will request in order to make the likely diagnosis? So I'll give you 1 minute for that. Yeah, so all have got it. Very good. So we are talking about what is the condition we're dealing with. Yeah, everybody? What is the child having? Come on. Yeah, you got it, right? So it's a intersusception, right? So intersusception is a condition that you should not delay in making the diagnosis, because if you delay, that can lead to necrosis of the bowel, and then the treatment of interception is hydrostatic reduction. Now when you have a child who has late presentation, hydrostatic reduction might not work, and it can lead to leaking, and also you can have more complications. So you have to have an open surgery for that. So the confirmation of your diagnosis is the ultrasound scan of the abdomen. Very good. Fine. Okay. Any questions? Right. So we'll now to summarize all the important things that we discussed about excessive crying. So it can be the presentation of a simple blocked nose to very severe, serious conditions. Okay. So we discussed some of the very important ones, and we discussed how not to miss any of those conditions, and how to make a diagnosis. It is a severe distressing scenario. Now, when you are parents, you would realize it's a very distressing condition when you have a child who is having excessive crying, because you don't know what to do. So, so baby can't tell what is wrong with that, with the baby, and mothers or parents also don't know what to do. So we'll distress that has to be understood, and they need a lot of empathy and also need some lot of support. So careful history of the crying episode is crucial for the diagnosis. So it's very important to ask about the history, okay, and go for the targeted examination and investigation. Life-threatening conditions that need early diagnosis and management. As an example, you might miss a SVT, you might miss a torsion of the testes, interception. So they are all life-threatening conditions, or not life-threatening. They need early treatment. Okay. Carefully thought about differential diagnosis and related clinical features help in the making the final diagnosis, and you follow that up with investigations. And I want all of you to develop a foolproof method to consider all possible conditions when a child presents with excessive crying. Now, what I suggest is to think of conditions from head to toe. Right. So with that, we will complete the first part. Now we will go to the next part. Give me a second. You want to rest a bit? 1 minute rest? Okay, I'll give you 1 minute to move about your arms and legs to go for the next half, right? Let me also have a cup of water. Shall we start now? Is it okay?
Okay, sir.
Yeah, fine. Okay. So we'll move on. Right. Okay. A 3-year-old child is evaluated for intermittent cough and wheezing for the last 2 days. The child has been well except for an episode of wheeze 3 months back. She had an acute onset of severe bout of cough which lasted for 15 minutes while playing with the 5-year-old sister on the previous day. On examination, child appeared febrile and has a respiratory rate of 36 per minute. Examination was normal except slightly diminished breath sounds on the right side of the chest with bronchi. The next step in the management of this child is arrange an urgent X-ray, immediate ENT referral, nebulize with salbutamol and re-evaluate, reassure and review in 3 days, start an inhale corticosteroid. I'll give you 1 minute to think about it. Right? Right. So almost all say it's A. Right. What is the condition we're dealing with? Everybody? Foreign body, exactly. So what are the features in the history? Now, this is a the preschool age is a typical age for foreign body. So infants, though they have inquisitiveness to put things in the mouth, they are unable to go and grab them. 3-year-olds they have. So that is one reason they are at a higher risk of developing having foreign body aspirations, right? So so when you have a child with suspected foreign bodies, you have to see the X-ray. Now, what will happen if the X-ray is normal? What are you going to do? So in this child, if the X-ray becomes normal, now what? What is the next step? Still, if you have a suspicion that this one has foreign body, then you can't just send them home, right? So then they need, your bronchoscopy. So you need to refer to the ENT surgeons to go for a bronchoscopy. And what type of bronchoscopy do you need to? So you need a rigid bronchoscopy to take this out. Okay, not the flexible one, which you are unable to take it out. Right. Good. Next. A 12-year-old child from poor socio-economic background is being evaluated for episodes of syncope associated with exercise. Apart from an acute febrile illness associated with arthritis at the age of 8 years, which settled on symptomatic treatment, the past medical history is uneventful. The most likely underlying disease condition is number 1, coronary arthritis following Kawasaki disease, hypertrophic cardiomyopathy, juvenile idiopathic arthritis, myocarditis, rheumatic heart disease. So almost all of you have got it, right? So it's a rheumatic heart disease. Yes. So what are the salient points in the history that suggests it's a rheumatic heart disease? Yeah. So one is the what? What are the salient points? Yeah. One is poor social background. Yeah. Then what else? Arthritis, exactly. So arthritis, now you don't need treatment all the time. It will get better, right? But the problem is it can bite the heart. So that's what has happened in this child. So they have been rheumatic heart disease. Very good. Right. A 3-year-old child is referred with fever for 4 days. On examination, she appeared pale and ill-looking. Cervical lymphadenopathy with 3 centimeters splenomegaly were detected. The full blood count showed white cell count 1.7, platelet count 15, HB 4.5. What is the next investigation likely to help in making a diagnosis? Child coming with fever and this blood count. First one is blood culture, one blood picture, bone marrow biopsy, chest X-ray, NS1 antigen. Somebody says C, B. Right. So most of you have got as blood picture. Yeah. So now you have to be very careful now. What I'm asking is, what is the next investigation likely to help in making a diagnosis? Now, the confirmation can be with the bone marrow, but I am asking, what is the next investigation? Now you have the blood count, and then we suggest you of, now probably you are talking about a malignancy, a hematological malignancy. So you do a blood picture next. But after that, so depending on the blood picture findings, you have to go for a marrow. Sometimes blood picture can be negative, like you might not see any abnormal cells, but still you have to go for a bone marrow biopsy, right? Good. Right. The current oral, now some MCQs, so all true false. The current oral rehydration fluid used in Sri Lanka contains 90 millimoles per liter of glucose, 75 millimoles per liter of sodium, 311 osmolality, sodium citrate, potassium 20 millimoles. Now, yeah, let's see. Oh, sorry. Do you see this, or can you see? Yeah. Right. Let's see now. A, what do you think? So somebody says true, 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 last one false. So it's a true false type, right? So you have to, so there are multiple true answers. True, true, true. Somebody says all true except the last. Right. Now, false, true, false, true. Yeah. So now you might know. Now we use this what do you call hypoosmolar solutions. Now the ORS now compared to earlier one, which had 90 millimoles of glucose. The current one has 75. Okay, and then sodium 75 is true. Then again, osmolality is now less. Is it the 245? Is that the currently used ORS solution we are using? Right? So sodium citrate is correct, and potassium of 20 millimoles per liter is correct. Okay. So now these are things that you might be asked. Okay. Right. Next one. Monophonic wheeze is typically seen in bronchomalacia, bronchial asthma, vocal cord dysfunction, acute laryngotracheobronchitis, foreign body lodged in trachea. So this condition I have mentioned, you have to read about, right? So if you are not very familiar with this, it's important to know about these conditions, okay? It's a true false type. So there are multiple true false answers, right? So somebody says true, false, true, true, true. Somebody says true, false, 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 true. Any other guesses? True, false, false. Right. Okay. Now we are asking monophonic V's, right? When there's a typically bronchial asthma has polyphonic, right? So all the other conditions, which are like a rigid, we have a fixed type of obstruction there, it gives rise to monophonic V's. So in that, apart from bronchial asthma, all the other conditions mentioned, they give rise to a monophonic V's. Bronchial asthma leads to polyphonic V's. Okay. Next, features indicative of inadequate control of asthma includes increased functional residual capacity, increased residual volume, FEV1 to FVC ratio of 92%, positive methacholine challenge test, increased concavity of flow volume curve in spirometry. So somebody says true, true, false, false, true. True, false. That is okay. True, false, true, true, true. Insert. True, 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 false, false. True, true, false, true, false. Right. Okay. Fine. So we'll see. So we all agree that increased functional residual capacity. Now there's a inadequate control. Then there's air trapping. So that leads to increased functional residual capacity. Okay, which that increased residual volume. So first two, true, true. Most of you got. Then FE1 to FEC ratio of 92% is quite good, isn't it? Right. So it's false answer. So less than, more than 80% is acceptable. And in children, you would see usually more than 90% most of the time, right? In normal children, but above 80 is considered normal. Positive methacholine challenge test is not a, it doesn't indicate inadequate control, but it's to test whether there is hyperactive airways. So that's what it checks for. So last one is a bit difficult. So some of you have got it. Increased concavities of flow volume curve is true. So when you have a your expiration is obstructed, that's lead to increased concavity. Right? So I want you to have a look at the flow volume curve in spirometry of different conditions, mainly bronchial asthma, and see how what is the appearance. Now in MCQs, sometimes to differentiate the more knowledgeable person, one or two of these answers you may see. Right? The first four, almost all of you, there's a high chance that first three, of course, most of you should be able to get. Fourth one, some of you will get, but last one, very few of you might get. So that's how the MCQs are made. So you might have one difficult one in the MCQs. Right? So that shows that you need to read. Don't just depend on the teachers to to get the knowledge, right? Not what you gain from them is not sufficient. Right. Next one. A 7-year-old child presents with facial pain, nasal block with a right-sided purulent nasal discharge for 3 weeks with poor response to treatment. The helpful clinical features indicative of the etiology of the condition includes. Okay, now difficult one. Number A, asymmetry of nasal passage, exercise-induced cough, dextrocardia, heartburn on lying down, persistent snoring in the night. Let's see who's going to get that. It's a tough question. True, false, true, true, true. Okay, you all are good. Good. Okay, carry on. Okay, so Ratnaik is good. Okay, T, F, T, 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 F, T. Okay. Right. So what is the condition you are dealing with here? Now, yeah. So what are the conditions? So condition you are dealing with? Anybody? Butsarni, you want to answer? Kasuni? What is the condition you are dealing with here? Yeah. So what you are dealing with is a sinusitis. Now going into like a chronic sinusitis. Now we are asking the helpful clinical features indicative of the etiology. So now you should know, you should be able to make a diagnosis of sinusitis, and you should know the etiology of sinusitis. What are the causes for chronic sinusitis, in other words? So one is when you have a asymmetry of the nasal passage, like when you have a deviation of the septum. Okay, then so Cardiac syndrome is associated with chronic sinusitis. So dextrocardia. Then heartburn on lying down means there's a GORD, that is gastroesophageal reflux, is a etiological factor. Persistent snoring, again, they are all risk factors. Okay, that is you have probably adenoid hypertrophy. Okay, they all can lead to chronic sinusitis. Good. Pharmacological agents used in the management of infantile seborrheic dermatitis include A. Moisturizing soap, emollients, topical low-potency steroids, oral prednisolone, antihistamines. Now, seborrheic dermatitis is a very common condition during early part of the infancy, right? So it's very common. So cradle cap is one of the feature of some of them. You will have thickened dry skin. You can have like plaque sort of a thing on your mainly of the face. It can coexist with infantile eczema as well. Right. So what are the, I'm asking, what are the pharmacological agents? True, 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 false, false. Okay, what else? Who else? So it's very important. Okay. So somebody's true, 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 false, last of false. Okay. True, true, false, true, false, true, true, false, false. Yeah. Yeah. So how you treat seborrheic dermatitis is Now, if it is only the cradle cap, so what you do is you apply some oil before about 1 hour before you give a bath, and then let the baby have a bath, and then comb the hair well so that you might remove the plaques. Okay, then if it is not settling, then you can have to use very low potent steroids, and you rub it on the scalp. Rest of the body you have to do not use soap. Usual soap will make the skin more drier and then make it worse. So you have to use moisturizing soap, and you use a lot of emollients, and you might have to use low potency corticosteroids topically, but you do not use oral prednisolone, and antihistamines are not part of the pharmacological agents in the management of seborrheic dermatitis. So only first 3 are true, other 2 are false. Right. The following is diseases associated with skin manifestations. Okay. First one, systemic lupus erythematosus, human herpes virus type C infection, dermatomyositis, Crohn's disease, oligoarticular juvenile idiopathic arthritis. It's an easy one. Let's see. True. Last one is false. True. False. True. False. True. Right. So almost all of you got right. Okay, fine. So I mean, you can get with juvenile idiopathic arthritis, but the skin manifestations are with at a systemic onset juvenile idiopathic arthritis, not with oligoarticular JIA. It's not there, but other conditions, yes. What is the condition you get human herpes virus type 6 infection? What do you call that? Not Kaposi sarcoma, no. It's a Roseola infantum, right? So Roseola infantum is what we call it. Human herpes virus type 6 causes. Huh? Right. Drugs indicated in juvenile idiopathic arthritis not responding to ibuprofen includes. Now, first choice usually is ibuprofen is the well tolerated NSAIDs that we use in the treatment of JIA. First one, naproxen, pyrazinamide, celecoxib, methotrexate, TNL, TNF alpha antagonists. TFTTT, FFTTT, all first, the last 3, okay, TFTTT. So all of you have got pyrazinamide as wrong, obviously, right? So it's an anti-TB drug, so it's not. So other, so it's a naproxen is a NSAID, celecoxib is COX-2 inhibitor. You can use. Methotrexate is used for resistant in JIS, and TNF alpha the same, right? So apart from B, rest is true. Right. Next, clinical features consistent with a common crate bite includes respiratory failure, bitten during daytime, ptosis, swelling around bite mark, passage of dark urine. Right, let's see now. TFTFT. So TT. Very good. Yeah. So most of you have got it, right? So crate bite is usually it's neurological and also with minimum bite marks. So basically, respiratory failure are the only respiratory failure and ptosis are the two correct answers. Others are wrong. So almost all of you have got it good. Following is are true regarding croup, that is laryngotracheobronchitis. Okay, presence of a loud stridor is an indication for admission. Associated Bs exclude the diagnosis. Self-positioning with neck extension indicates severe disease. Oral dexamethasone 0.15 mg per kg is indicated for mild disease. Nebulization with 5 mg of adrenaline is recommended for a 10 kilo baby. Right. Okay, you can answer. No answers. Okay, TFTTT, TFTTT, FFTTT. Okay. Yeah. So now the loudness of the stridor is not an indication, but if you have now, as you know, croup is a laryngotracheobronchitis. So the problem of laryngotracheobronchitis is it can lead to the main issues of obstruction of the laryngeal area. Okay, and so it's a the stridor is the more important feature there. So if you have stridor at rest, now if you have only stridor during when the baby is crying, then that usually is a mild form. But stridor going on with each breath is an indication that is a severe obstruction. So they need admission. So if it is stridor at rest is an indication, but loudness is not a feature. So it can be associated with wheezing as well. So it doesn't exclude the diagnosis. Okay, and other three are true. Right. Invasive MRSA infections are effectively treated with A. Meropenem, B. Co-amoxiclav, C. Vancomycin, D. Flucloxacin, E. Linezolid. Right. You say T, F, T, F, T, T, F, T, F, F, T, F, 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 T, F, F, T, F, T, F, T, T, F, T, F, T, F, T, F, T. Right. So your meropenem is wrong. You can't treat MRSA with that. Co-amoxiclav is also wrong. Vancomycin, yes. Flucloxacin, no. Linezolid, yes. So basically, you have only two true answers in vancomycin and linezolid. Okay, others are wrong. Right. Okay, the diagnosis and the definition is correctly matched in A. Wasting. The BMI is below 5th centile. Okay, answers again there. So that's okay. So wasting, the BMI is below 5th centile. So I think you saw the answers. No, so no point going there. No? Right. So I think that's it. So we will stop from there. So you can answer any questions on things that we discussed today. Any questions? So what I suggest to you is, now when it comes to MCQs, it's very important to read around the patients that you see in the wards and the conditions that you are talked about during your clinicals. So then you expand your knowledge. So what you hear from your teachers is certainly not going to be sufficient for your MCQs. So you do more and more MCQs, you will learn more. So when you keep on doing about maybe 300 or 400 MCQs, you will find that most of the conditions are getting repeated. So you know what conditions to read more. I mean, they will be one you will be tested on mostly. So rarely you can be tested on common cases, but most of the time you'll be tested on the clinically important conditions, right? Right. So we'll stop from there, and I hope that you might have got something from today. So next week you are going to get, I think, medicine topic. So again, thank you very much, and another invitation for all of you to become members of PeMSAA. So get into PeMSAA so that you can help your juniors to come over a period of time. You can do a lot to help them. Right. Okay. So we'll call you today. Okay. Thank you very much then.
Sir, thank you very much, sir.
Yeah, thank you. Good night.
Good night, sir.